Good afternoon. My name is Adam Rubenfire, and I'll be moderating today's Modern Healthcare webinar, Rethink Your Clinical Space, Improving the Caregiver Experience to Enhance the Patient Experience. In this webinar, we'll share how healthcare organizations can enhance the caregiver experience at the point of care. The consumerization of healthcare and the rise of value-based care models have put greater focus on the point of care experience. While much of that focus has been on patients, systems are recognizing that enhancing the caregiver experience is critical to achieving their mission. Caregiver experience can greatly impact the overall quality of care and lead to better clinical outcomes. Both are essential to the clinical and financial success of any healthcare delivery organization. We'd like to thank the sponsor of today's webinar, Midmark. Midmark helps physicians and care teams deliver exceptional patient care with better equipment, smarter workflows, and integrated technology. For more than 50 years, Midmark has used its knowledge and unmatched understanding of the ambulatory care space to help its customers improve clinical outcomes and eliminate the barriers preventing seamless, well-coordinated patient care. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for you, our audience. You're encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. In addition, if you would like to minimize the attendee panel for a better view of the presentation slides, click the double arrows at the top of the panel. You can also resize the webinar window by grabbing the corner of the screen with your mouse. I am privileged to introduce our speakers for today's presentation. Dr. Tom Schwederman practiced family medicine for 12 years before joining the team at Midmark. As Vice President of Clinical Affairs and Chief Medical Officer, he leads the company's focus on innovative technology and new approaches that enrich experiences between caregivers and their patients at the point of care. Much of his time is focused on advising the development of clinical solutions, recognizing and understanding market trends, monitoring and providing insight on government regulations, and identifying and quantifying new innovations in the medical, dental, and animal health markets. Dr. Schwederman is board certified and continues to practice medicine. Kurt Forstoffel is the marketing director of the medical division at Midmark Corporation, an industry leader in medical examination and procedure room equipment, diagnostics, and workflow solutions. In his position, Kurt supports Midmark's commitment to supply healthcare providers with solutions that enable the most effective and efficient patient care. He is responsible for managing the integration of equipment and diagnostic segments, product and services marketing, and clinical product support for Midmark's medical division. And with that, we're ready to begin the presentation. We'll start with a poll that I will get loaded right now. And our first poll is, how much do you currently focus on improving the provider experience across your healthcare facilities? Do you have a high level of focus on the provider experience? Provider experience is just one of many factors. The patient and provider experience has equal focus, or is the provider experience not something you can focus on currently? You can choose one answer. We'll give you just about 45 seconds.
Hey, Adam, this is Dr. Tom. Thanks for the kind introduction. I love these poll questions at the beginning of the webinar. It allows us to sort of tailor the presentation. So I'm interested to see what the audience answers here, so we can make our presentation fit the needs of the audience.
Well, wonderful, audience. We'll give you about 15 more seconds, and I think you'll be interested by the results. We're getting a pretty wide variety, Dr. Tom. So we'll just give them just a few more seconds. All right, audience. We are going up. All right, we're going to close the poll and we'll show the results. Tom, can you see those results?
Yeah. Yes, they are pretty much across the board, but the one that is definitely in the low end is the last one, which I'm hoping we can influence as 11% to put more focus on it.
Ready to move on to the next poll?
Yes, please.
Wonderful. Our next poll. And this is a choose all that apply, folks. At what stage of technology integration is your exam space or exam spaces currently? And so you can choose from, we have only implemented EMRs. Our providers have mobile devices to connect to the EMR. We gather data electronically to enhance workflows, or we gather patient data electronically for care management. Choose all that apply, and we'll come back to you in just about 45 seconds. Dr. Tom?
Sure. This will tailor right into the beginning of the presentation where we talk about the growing data sources that are becoming inherent to value-based care. So it'll be interesting to see how far along the audience is so that we can, again, tailor the webinar towards that need. So this is one that you check, I think, every 3 months. It would be a different poll answer, I think.
Sure, good tracking poll. Audience, about 10 more seconds before we close this poll. So if you want to vote, get your vote in. All right, we're going to close that poll and show you the results. Dr. Tom?
Equally split.
Yeah, go ahead, Kurt.
I was going to say there's very equally split. I expect to see a little bit more diversity across these, but I suppose that's probably a good thing that there are people that are in the advanced stages of advancing their exam-based technology.
I completely agree. This is going to make for an interesting webinar. So very interesting. You could go ahead and move on to the next slide there, Adam.
Wonderful.
So today's webinar is going to focus on, as the polling question suggested, what the role of digital technology is playing at the point of care, how it's changed. We're going to put some emphasis on the second bullet here, which is the provider experience and why it matters, why it's something that I think all of us should take very careful attention to. And then we're going to talk about how we think the point of care can be empowered by technology and some of the steps you want to take. But I'm going to pass the ball off to Kurt. And Kurt, I'll let you introduce the next two bullet points.
Yeah, we'll then take the webinar in another direction, talking about promoting technology, integration at the point of care, and also speak to 5 different considerations for integrating technology into the future of your exam space.
And then I'm going to close it out with a little bit of a discussion on why this will be so essential for the future as we start looking at the more advanced technologies such as artificial intelligence or machine learning or complex analytics. At some point, all this is going to be a fundamental need for you in your exam space. So let's get started, Adam. Next slide. This slide is interesting to me because it fairly closely mirrors my path as a physician in the marketplace. Back in 2000, 2001, the EMR was not a common feature in the physician's exam space, but as we all know on the phone, this has gone up dramatically over the last 15, 20 years. And I'd even argue today, this 86% has probably even gone up higher when you consider the physicians who are normally independent and had to fund this, under their own dime are now part of larger systems where the access to the electronic health record is a far easier feat. I'm guessing that we're seeing this number even go higher. What also is happening concurrently with this on the right side is, and I'm pleased to see many of you answering that mobile apps and mobile devices, home-based diagnostics are becoming more central to your decision-making because this is a relatively new phenomenon that's just adding a whole nother dimension to it. So it's not just the provider data in the EMR. We're now starting to see consumer and patient-generated data sort of infuse this complexity as well. And I want to emphasize that during this path of digitization of the exam space, we're seeing a lot of other things happening at the same time. Medicine has not stopped advancing. In fact, I'd argue it's advanced even faster with the doubling of medical information now, spanning in less than a year's time. You got medical formularies, you've got changes in disease management, you got new regulatory requirements. So the point of care's complexity just continues to expand, and I'm not so certain that the exam room scenario has adapted at the same pace of the digitization problem. So we're going to kind of walk through that a little bit further. Next slide. So we live in an extremely large marketplace within the U.S. $5.3 trillion is an enormous sum. One of the largest industries in the U.S. economy. And if you look at all the factors that go into it, it comprises, a tremendous amount of digital technology. Unfortunately, what we've seen, though, is sometimes this technology is not implemented to the level of efficiency that it could be. And a study just came out from McKinsey that was pretty interesting. It pointed out that there is a potential for a net savings of 2.6 to 3% of this $5.3 trillion budget that could be reduced with better technology-driven improvements in productivity and customer sat and the like. Now, granted, a lot of these findings were not specifically just around, workflow efficiency and, better templates and less clicks. It also included, easier identification of gaps of care and other somewhat clinical modalities. But to put a figure on this, 3% of a $5 trillion market is a lot. Just take this little illustration to kind of give you your arms around it. You take the entire Medicaid budget of New York, Florida, and Texas combined, and that is what 150 to 160 billion dollars looks like. So there's an enormous amount of value to be achieved or to be gathered by health systems out there by really looking at technologically driven improvements in productivity and areas that drive customer and patient satisfaction. Not to mention even the health outcomes that could be delivered, which in a fully baked reimbursement model around value-based care, I would argue this number could even get higher because there's a lot of inefficiency, as all of us on this webinar understand. Next slide, please. So how, during these 20 years, has the digitization process, how has it been experienced by us in the care team environment? There are mixed results. This first slide here is really the negative side of it to some extent. I do have the next slide is going to be more positive, but if there was a poll done by the Future of Healthcare report of 3,500 or so physicians, and they looked at how has this impacted your care delivery? What is your experience with a patient in the exam room now that this EMR is part of your lexicon? And 54% of the physicians in this poll, which is 1,500 or 2,000 or 3,500, felt that it was a negative impact on their relationship. And they also said in a larger number that 61% that the EMRs had negatively impacted their workflow. This reminds me back when I started my career. I went to one of the first medical record conferences down in San Antonio, early 2000, and they had these competitions where they would have a patient sitting on the stage and have 3 different EMR vendors with large screens, and they would be documenting the encounter as it occurred, the fictitious encounter in real time. And it varied between 7 and 12 minutes to document a patient encounter, which is an enormous amount of time when you think about the patient scenario. So I think the EMRs have gotten tremendously better than that, but it's still somewhat of an issue regarding productivity. Another study on the left is the Lehigh Valley Health Network. They proactively looked at what would happen if you implemented an EMR and the patient satisfaction, and they found that by and large, the EMR was not accretive to a positive patient experience. One of the quotes from that study said the following: "It is striking that we did not find a single positive effect from the full integration of EMRs." So Lehigh, I'm sure, has fixed that problem by now because this was a few years ago. But they did acknowledge in their study, and I'll quote again, they did acknowledge the results did improve the information transmission and its potential to improve care. So we've taken a step forward in information and data analytics and the ability to see what's going on with a patient. But in many respects, some of the EMR integrations have left the patient and provider, in many cases, dissatisfied. Next slide. Now, the VA did a study, and this was another very interesting study just a couple years ago. And this study was 23 clinicians, mostly in internal medicine. This was in the southwest of the U.S. in San Diego. And what they did is they fully recorded 126 office visits. I'm imagining multiple cameras in a room because they were analyzing all sorts of dynamics between the provider and the patient. One stat that jumped out at me on this study was that the average clinician scrolled or clicked almost 200 times, with many of them, and they emphasize many, going much higher than that. They actually had a single office visit in this study with a clinician was doing 685 clicks and scrolls. So clearly you can see how this impact of the electronic systems in that room has changed the encounter. But they took this analytics a step further. In the past, I've seen many occurrences where FaceTime and how the physician and patient interact is a critical part of the satisfaction. Well, they took it a step deeper into granularity, and they actually looked at what they called gaze time. How long is the patient and physician actually eye to eye and having that intimate encounter of sharing information about their condition and disease state? And this was the one statistical factor that was the most tightly correlated with a high p-value of significance to the customer and patient satisfaction. So it's really important when you're thinking about the digitization practices of your exam space at the point of care that you do whatever you can do to preserve that gaze time between the two physicians. And I'll link back to the Lehigh Valley study. That was one of the patients' pushbacks, was they felt like they weren't getting that gaze time that they normally had with their doctor, and that was a detractor to their overall experience. But I want to emphasize again that I picked these two studies because I thought they're fairly representative. In my meta-analysis, which was not particularly scientific, but informative to some extent, I found it to be about 50-50. But if you balanced out the negativity issues and how negative they were and the positivity issues and how positive they were, the net, I think, still resides a little bit below the line, and that the overall patient experience, I think, has not particularly been enhanced by this. Now, remember, I'm just talking patient experience with their physician and how well they felt the connection was. I'm certain that the clinical outcomes have been impacted by the better data analytics. So next slide. So let's take a look at that provider piece. As a provider and having lived through this digitization process over the last 20 years, I think it's taken a toll. JAMA did a study just last year in 2018, and they looked at the provider and how well the provider is going through this digitization process. And they focused on a word they called depersonalization, which is this rise of cynicism, sarcasm, the need to vent. They found that this depersonalization was a leading factor in how physicians and providers of all types experience burnout. So what they found too, and they did a meta-analysis of, I think, 15 to 20 different studies on this topic. And they brought all that data together, and they found that it was quite consistent that a burned out, frustrated, cynical physician is less productive and just as, and probably more importantly, more likely to make medical errors in the process of patient care. And even if they're not making overt medical errors, they have a less tendency to be less appropriate in their prescribing behavior, and of course have lower patient satisfaction scores. I've seen other studies that indicate that physicians who are burned out have a strong tendency to just order more because it's easier as a physician to just order something rather than to do the discernment of thought around whether this patient truly needs it. At the end of the day, when you lose productivity, you have more errors, have less appropriate provider prescribing behavior. Clearly, the outcome is a less profitable system. That's the sort of kind of clinical study approach to it. On the financial side, I remember seeing a really well done study that showed that the systems that had the highest physician and patient satisfaction also tended to be the most profitable. So I feel that this provider experience is really an area of needing some deeper insights and deeper innovation. And I think if you think about the things I mentioned earlier, the formularies, the new medical advances, the complexity of disease care, and then throw this digitization on top, I think we've sort of overwhelmed the ability of a physician to really handle all this in real time. So I think right now we're in a great position to really rethink how all this technology is being utilized. And I think as we go to the next slide, Adam, I think we got to divide this technology into two specific categories that will give us a sort of a different perspective to look at it. I would argue with you that technology done poorly is a direct cause of clinical burnout, and the JAMA study that was showing that EMRs are the top issues of frustration, I think pans that out. But I also feel, being somewhat of a technologist myself, that I think it's technology that also will relieve the clinician of that burden. On the left side, in the darker blue, we need to look at all that data that happens in that exam space, including the new wearable data and the things coming in from the home, and find ways to automate as many attributes of that as we possibly can, and optimize the EMR so it can efficiently track and document the encounter. I'll give you a little quick story. We had a consulting arrangement with a practice to just investigate, their workflow and how well it was being managed, how well the patients were tracking through the system. And we did it in a way that was somewhat creative. We asked the staff to predict how long patients were waiting, how long it took them to check in, how long they were with the physician. And then we actually measured it using our RTLS, our real-time locating system technology. And so we analyzed the perception of the office staff and then followed up with the real data. And what we found is that on just about every metric, the prediction of the staff was less than the actual numbers. So the wait times are longer, the check-in time was longer. In one case, one of the older physicians had definitely lower productivity, but he certainly seemed to be working just as hard as everybody else. And to this bullet point on the EMR, it was taking him close to 12 or 15 minutes at times to document the encounter. And so one of our mitigating factors was we came in with a specialist in that EMR. We optimized it. And during the optimization process, found that the system had not even been touched from an optimization standpoint for 8 to 10 years. And it made a profound difference in the ability of that physician to document. In addition to that, we immediately saw the patient face time and the gaze time improve just as well. So as few clicks as you can get around would be advisable, and I consider these synergistic. If you reduce a click on issue A and issue B and issue C, I think the 1 + 1 = more, because it just creates a synergy of efficiency. On the right side, though, this is where my art of medicine brain kicks in. Medicine is both an art and a science. The art has to be maintained at all costs. This eye contact, the gaze, as we talked about in that clinical study, take the barriers away. If it's a physical barrier like a piece of equipment, or there's something that doesn't quite give you access to the patient, that needs to be removed. And if it's a soft barrier where you're forced to do something in the EMR that has you turning your back to the patient, we got to find ways to really empower the provider to bring these tools to life so that the data, the analytics, the insights that they provide aren't coming at the expense of that humanistic experience between two people. And one of my favorite topics is how important this human element is in a care exchange, especially when you're trying to influence a patient away from bad behavior into something of a healthier behavior. You just can't do that with just data. You have to do that with an encounter capability. So next slide, Adam. So what we aim to do here is simplify the complexity of this environment. With all these new facets coming into play, we'll need to find technology that actually takes some of that barrier and some of that burden away from the physician at the point of care. An analogy I like to think of here is if any of you have the opportunity to drive in a luxury car, there's some really highly advanced technical engineering feats in there, whether it's crash avoidance technology, automatic steering, automatic cruise control, the ability for lights to point out in your mirrors to say someone's in your blind spot. All of that's done with the absolute engineering focus on improving the driver experience. Now, all those technological adds create a safer, more pleasant, and probably more efficient driving experience, but the driver experience is the one thing that actually elevates the highest in my perception. So I think we're at a point now where the innovative cycle of technology needs to start switching over to things that actually make this experience better. And we're going to give you a few steps on how to proceed down that reasonably complex path, but I think we have some good ideas. Next slide, Adam. And I'm just going to introduce these ideas, and I'm going to pass it along to Kurt to kind of give you an approach to how you would look at this environment and with a different vantage point, one that's more focused on, again, the experiential attributes and outcomes. First, find barriers. Walk around your facility and go in with your physicians with the perception that is there something coming between the patient and the provider that doesn't need to be there, physical or virtual. Second, can you address any inefficiencies that are occupying time? As Kurt will point out, there's just an enormous amount of time spent on that computer, and every percentage point matters. Safety issues, of course, as we said, burned out doctors overburdened with tasks can be a real safety threat to poor prescribing or inappropriate decision making at the point of care. And then finally, as we get more into value-based care and we're both directly incentivized for patient experience in our care measures and incentive compensation, but also indirectly a better experiencing from the patient's vantage point makes them more activated and they're lower cost, they're better resource utilizers. So Kurt, I'm going to pass it over to you to kind of walk through some of the approaches they can take.
All right, thank you, Dr. Tom. Quite simply, the big million-dollar question is, where do you start or how do you get started? And the simple answer is to start by simply promoting the idea of technology integration at the point of care in ways that specifically make life better for clinicians and patients. Start by assessing your facilities, as Dr. Tom started to speak to, point of care landscape, and imagine possibilities of recreating your exam space in a new, thoughtful way. One of the most important aspects of that is involving your staff, especially the caregivers, in identifying what technologies make sense and what other benefits to patients and caregivers. Pay as much attention on the how the technology impacts care delivery as you examine the what the technology typically does in the clinic. And most importantly, look for new opportunities to create clinical environments that support workflows, that integrate technology, and maintain patient-caregiver relationships. And as Dr. Tom had been speaking to, find ways to boost the human aspects wherever that's possible. And don't be afraid to consider eliminating steps altogether if they don't add any value to the process. And as a rule, consider that unburdening the provider, perhaps by assigning tasks to other members of the care team. Is there new technology that allows those with maybe less training to be equally as effective in a clinical or clerical task that is used to require a higher level of training? An example of this might be systems ordering for and acquiring routine lab orders. Next slide, please. And when you're assessing your exam space, there's three areas of focus, and that's limiting electronic barriers, which in this case speaks to the fact that as much as 37% of a provider's time in the exam space is spent either working on the EMR or doing work at their desk. And that's an enormous amount of time that is spent doing that type of work. So how can we remove those ultra-human or enhance those ultra-human elements of the exam experience to make even better, more intimate workflows, more seamless, and more powerful for the clinical team? Just think, if we could reduce the 37% of the time spent by caregivers in the EHR and desk work, how much that could impact that patient-provider experience. Engagement is the key to any change management, and the exam room needs to foster this wherever possible. Remember how Dr. Tom spoke of gaze time. and its impact on patient satisfaction. This is a direct relationship to that patient satisfaction score. Next slide, team, please. And here are some steps that I'll walk through quickly that speaks about some techniques or 5 steps, how you can integrate technology in your exam space. And there's 2 things that we need to think about when we're applying these steps. One, look for things that could and should go all digital, and also look at exam room functions which need to foster an intimate experience. And these areas should be very fiercely protected. Next slide, please. From a compatibility perspective, at the heart of technology integration is to evaluate technologies within the context of your clinical work environment, your existing work environment. So some questions you should ask in this area when you're looking at compatibility is, does a technology truly add to your clinical care? Can we hide technology somehow? Maybe make it less discreet, less invasive, and less threatening in an environment? Can we automate anything by its use, by technology's use? Can we remove the human element altogether, which would be ideal? Do we need to consider how workflows may need to change by the integration of this technology? Is it flexible enough for projected growth? Can I scale this technology across all facilities so I can have some standardized approaches to care? And what value does it offer to the point of care? Because in the end, when you determine the value, you need to add a cost, if there might be one, on the provider. Are we adding some other technical burdens? Are we adding extra clicks as Dr. Tom was speaking to? And does the clinical value rise above those costs? Next slide, please. In the exam space workflow, there's a couple different ways to assess technologies, and that's around how does technology fit in your existing workflow, and would this technology really enhance your existing workflows? A few questions to ask here might be around what adjustments need to be made. Well, what workflows should be changed or possibly eliminated altogether? Would the technology require new workflow? And or how can technology enhance your workflow? You also need to consider which team members are most impacted by changes to workflows, and do they have time or willingness to make the change? This is an issue where we really need to look at change management principles and how do we get teammates in the exam space to embrace these changes. Another area to think about is, does the workflow change offer the elimination of another step? If not, we need to think of the clinical value. Is the clinical value sufficient enough to warrant the new added potential technical burden on the exam team? And there's other technology out there that can be adopted in these systems. There's real-time locating systems, or what people call RTLS for short. It's a great example of how technology can provide insight into the clinical environment. Dr. Tom was speaking of some of these studies where people were asked how much time they spent doing tasks, and they consistently underestimated the amount of time spent. But when you're using an RTLS type system, you can capture clinical workflow data. You can look at real-time location data on equipment and staff. You can evaluate patient wait times and retrospective details for evaluation at a later date and time so that you can enhance the flow of your facility. There's also ways you can use the data to improve patient flow by implementing patient self-rooming, which is a great example of eliminating a traditional step with technology, giving some new advantages to both the patients, which enjoy that aspect of not having to sit in a waiting room, and to providers who do not have to provide the services to support rooming patients. This is as close as to auto parallel parking in an automobile as anything else that's available. RTLS is a great example of adding information on your workflow on a completely passive basis. The information can be easily consumed or analyzed in the real time or at a later date and time. and it can be really used as a way to look at process improvement within your facility. Next slide, please. And now we speak about connectivity. Technology advances are bringing healthcare to realizing a truly fully connected ecosystem within the exam space. The connectivity available today enables digital elements of the exam room to automatically occur without maybe even encompassing the use or the engagement of the care team. The real challenge here is to determine the level of connectivity and technology can offer and how it will connect with the ecosystem you're creating. So when instilling or looking at technology for the exam room ecosystem, think long and hard about asking the care team to do new stuff. Again, this is a change management issue because we've reached the point where those tasks are very difficult to ask providers to do more and more within the exam space without demonstrating the benefits of doing those tasks. Next slide, please. And the last two items to speak to are around setup and staff engagement. Proper installation of these technologies within the exam space can be challenging, but it's absolutely essential to work with your providers or whoever is providing that technology, because without the proper installation or integration between systems, the promised performance levels and expectations can fall way short of what was expected, and that can provide a higher level of dissatisfaction amongst your staff than what you may have experienced prior to trying to implement the technology. So it's really essential to coordinate installation and follow detailed setup plans with the installation team in order to reduce headaches in the future and to provide better provider satisfaction. And lastly, as we mentioned earlier around staff engagement, it's very important to involve the staff early when you're speaking to new technologies. They're the ones that are going to be using it every day. They're going to be the ones that maybe understand how best to deploy that technology in the exam space. Make sure you're maintaining open and honest communication about what technology is coming, proactively address any questions that they may have or concerns, and be available to explain or demonstrate the benefits are the best course of action in this situation. What we don't want to do is repeat some of the past sins in the healthcare industry when we were doing the initial EMR rollouts. They promised nirvana and they grossly underperformed. Subsequent evolutions of EMRs have addressed a lot of these issues, but it has left a very negative connotation around technology in the exam space. We really need to empathize with our care teams and ask directly if the innovation actually makes things better for them. And of course, offer hands-on training and the ability for them to share feedback with the technology team that's doing the installation. Next slide, please. And when we talk about technology, it doesn't always have to mean digital. Sometimes technology can just be an innovation of how to do something better. Here's an example where the design of just a computer workstation can impact that gaze time that Dr. Tom has been speaking to. The entire design of this product here was based on provider-patient experience. For the provider, it adjusts easy to virtually every provider body type, and it does so easily with one simple step. So it's easy enough that providers actually will make adjustments when in use. There's a lot of technology or devices deployed that people do not maybe make the available adjustments because they don't understand how to do it. So whatever you deploy, make sure that it's easy enough for people to quickly and easily adapt and understand. And in this case, for the patient, what it does is it allows the provider to maintain full eye contact with the patient throughout the engagement. And it's easier to roll out of the way when not needed or not appropriate, and it removes a physical barrier that can be between the patient and the provider. And this really brings the provider closer to the patient. And with that, I'm going to turn it back over to Dr. Tom.
The last slide was interesting, Kurt, because it made me think back to the Lehigh Valley study, and one of the study constraints was that the workstations were fixed. They were set on a desk next to the exam table, and the patients sensed that the physician wasn't exactly with them the whole way. So that cart issue is a really interesting concept. This is really where what it all starts coming together. I had the privilege of attending a conference of 20 or so chief medical officers from across the country. We had some of the top names in pharma, med device, health systems, payers, and the discussion was around how do you define value and where is this value concept going long term. And with that, all of us sort of added some context to the conversation, but it really boiled down to this unbelievable need for data. We need data at the point of care. We need all the data attributes we can possibly get our hands on. And we're seeing this new influx of next generation data, which is genomics and social determinants of health and wearables. As we see, already 25% of physicians are using the wearable data within their clinical decision making. We're also seeing data from the EMR get meta-analyzed in these newer, larger top health platform systems. So what the takeaway here should be is that, we have seen a dramatic uptick in the amount of digital things happening at the point of care. I think we've only seen the beginning of this. And if you were to pay attention to some of these new futurist reports, some things like McKinsey or Price Waterhouse will come out. They're constantly pointing to the fact that this new generation of data technology and analytics is going to transform how healthcare is delivered. It reminds me of the days of my hometown when I practiced medicine in a small town, and you had this inherent understanding of a patient simply because you lived with them, you knew all about what their job was about, what their uncles and aunts and kids were about. And you had this context of data to help you kind of say, okay, how am I going to influence this patient to do better? Well, I think some of that ability you have in that small town is going to be given to the doctors at large with some of this broader data sets. They're going to have a better insight capability. What's driving this patient? What's driving this patient's disease manifestations and the like. And when we talk about optimizing your point of care to be physician-friendly, patient-friendly, and bringing all those data sources as efficiently as possible into the context of your care environment, I think it's essential we start doing that today, because as you start tapping into these new sources of clinical power, I think you're going to really see the haves and the have-nots separate from themselves regarding profitability and clinical outcomes. I think these tools you see on the screen here are really going to differentiate the truly great health systems from those that are not so great. And I think we have a window of time to get ourselves prepared for that and paying attention to those 200 clicks, eliminating 5 clicks, or improving your gaze time by putting the right equipment in a room so the doctor and patient can exchange data information more effectively. All those add up, and I think we're at a point now where we need to kind of, get the house ready for what I feel is going to be coming down the path. So, with that, I'm going to pass it back to Adam for some discussion, and I'll be happy to answer any questions for both Kurt and myself.
Well, wonderful. Thank you to you both for such a phenomenal presentation. Audience, if you have questions, keep sending them in. We're going to start with a few, but we welcome you to send in your questions. We'll take questions for about the next 10 to 15 minutes. So please, if you have questions about how you can improve your point of care experience for both patients and providers, go ahead and send those in, and Dr. Tom and Kurt will get to as many as we can. But Tom, I'll start with one question for you. If a provider is unable to integrate additional technology into the clinical space in the near future, so if it's just not an option right now, where should they start to begin the journey of improving that experience in the clinical space?
Well, as we pointed out in that last series of slides, it doesn't always have to be technology that or digital type systems that are impactful to improving the patient care experience. I think, as Kurt pointed out, there's some steps you can do in your normal daily workflow that could make a big difference. One is just offloading the clinician from any clerical type tasks by, allowing a caregiver, a member of the caregiving team, to do it before the doctor or after the doctor gets in. Another example would be giving the authority for some of your MA or nursing staff to automatically order tests or things that are going to be needed for that patient encounter. Get those pre-populated in your EMR so the physician doesn't have to hunt and search for those things. And again, if there's anything in the room that's interrupting that experience between a doctor and a patient, we call them monuments in the industry, where there's something sitting in the room that is just not conducive to that sort of humanistic relationship. Get rid of it. Find a way to get rid of it or upgrade it to something better. I think we've reached the tipping point of just putting new technology, assuming it's going to add value. I think when we talk to health systems, we're finding that they're more discerning about, okay, can my teams really absorb this or not? So if you're not ready to move forward with the digital side of things, just go back to old school. Finding ways to offload work from the provider.
Great. And Kurt, can you elaborate on how some of our audience members, how they can eliminate the barriers to the human interaction involved in providing care? I think you talked a little bit about how important engagement is to kind of these outcomes we're trying to establish.
Sure. If you remember the traditional exam space, it used to have like a 3 or 4 foot drop down desk that was opposite side of the exam table or chair in the room, and whether the physician was using paper charts or the new EMRs, they would turn their back to the patient and to make notes and refer to documents and records, and they would go back and forth like that. Something as simple as just removing that type of tool or piece of equipment from the exam space allows the patient and the provider to just maintain better physical eye-gaze contact, as Dr. Tom was referring to. Simple procedures or steps like that can really add a lot of benefit to the exam experience for the patient, and for that matter, even the provider, because the provider, I'm sure, does not necessarily enjoy turning their back on the patient. And simple steps like that, even before you even think about spending money on technology, you need to look at your entire patient engagement process and see what simple steps you might be able to do before you think about investing in equipment or new technologies would be the best and fastest way to impact that patient caregiver experience.
Great. And another question we've got for Tom. Tom, you mentioned patient self-rooming, and we're being asked, what does that look like? Could you elaborate on how self-rooming works and kind of best practices for that?
Sure, I'll give it to you in 2 perspectives. The one is the medical clinical perspective of the value of patient safe self-rooming. There's a lot of times when I was practicing medicine that I would go into knock on room 1 to enter the door, and the patient wouldn't be there, and the nurse would say, "Oh, I need to go get them from out in their car." And it never made sense to me so I asked the patient, "Why are you waiting in your car?" I said, "Well, I don't want to be around all those other sick people in the waiting room." Which there's some logistic logic to that. So I think not having a patient exposed to other patients in the exam waiting room is a good thing. On a financial side, there's not a whole lot of space in the clinical environment that is almost a zero value add, and that one of them is the waiting room. Essentially, you're not generating any revenue in that waiting room. It is warehousing, if you will, to use a kind of a cold term, your patients till they're ready to be seen. And I think patient self-rooming also mirrors what we're seeing in other parts of the economy. When you travel today, You can check into your hotel room. In fact, last week I could check into my room and actually unlock my door with my cell phone. It's just a sense of power and autonomy that I think patients would enjoy. And as Kurt pointed out, these steps where you offload a staff member from having to walk 20 steps to go grab a patient and walk 25 steps back to the room, that's just time that's not well spent. And so having that little extra time during your day can have a material impact on the overall workflow efficiency. So self-rooming, I think, is something that I sense is coming up as an innovative way to solve, again, both clinical and operational issues at the same time. I don't know if Kurt, you have anything to add to that, but
no, I think you pretty much nailed it on the head there. I think when one of the benefits to the patient not only is empowerment, but the simple fact that they do not have to sit in an exam or a waiting room, rather, that might be populated with people who have contagious colds and such. So it keeps them out of that environment.
Mm-hmm. Tom, a really interesting question that just came in from the audience. Have you considered integration of family members in the exam room and how that affects patient and provider satisfaction, given that another voice in the treatment room is taking up a little bit more time, despite an understanding that family givers add value through their observation? So a little bit of a long-winded question there, but the idea being, have you thought about the family member's role and what that does to provider and patient satisfaction, given the benefit of their voice, but given the fact that it may lead to a longer exam?
Well, a personal story. Absolutely huge value in having family members in the exam space. They said 80% of healthcare, I didn't say this, but 80% of healthcare happens outside of the exam space, meaning the decisions you make with your food and how well you exercise and all the like. And it's a very much a black box for many physicians on what that looks like. And in my practicing days, I was very much attentive to the family members that were in with my patients, because you could read their body language. If the physician said something or the patient said something and the caregiver there winced, you kind of knew there was something there, and you could kind of investigate that a little further. And in addition to that, I would often find a way to talk to the patient's family member, independent of the patient, to just kind of corroborate if it was a case of dementia or something like that. It often added tremendous insight. This is one area where I think technology might be a real asset to the industry, and I'm kind of looking into this myself personally, whether there's an opportunity to Skype or video chat somebody in the exam room, both physically be there, but also virtually, perhaps. If you have a healthcare power of attorney who lives in Colorado and you're in the center of Ohio, it'd be an opportunity for that person to participate in the exam visit as well. So I think this is not going to go away. I think having caregivers and family members participate in the exam experience is something that I think is going to both be maintained and perhaps grow. I think it's a critical part. And in our designs of exam rooms, we absolutely have requests from health systems to make sure there is a couple chairs in there that are strategically positioned so they can participate effectively.
Great. Kurt, anything to add before I throw another question to you?
No, ready to go.
All right. So one of the most important issues we're facing today, that health systems are facing today, is standardization. Given the onset of value-based care, health systems really are faced with reducing clinical variation and making sure that they can control outcomes and keep and maintain costs, either reduce costs or keep them at an acceptable level. How can implementing technology standardize some of the basic functions that we're doing in the exam room, vital signs acquisition, for example, and how do we get caregiver buy-in on changing these techniques?
Well, that's a great question. I think the challenge there is to try to eliminate variations in capturing some of these vital signs, which is the idea behind standardization. There's technology out there, what they call automated vital signs that can be used in the exam space that standardizes how those vital signs, like blood pressure, for instance, is captured. And it takes away the human element. Not that the automated vital signs capture a better blood pressure reading per se, but the fact that it does it the same way every time makes that data more comparative over time, rather than having multiple care providers capture that blood pressure vital statistic, and you're not exactly sure how significantly different the changes over time are. Whereas technology can help you standardize that, and it's something that you can scale up across a facility or even a healthcare network.
Yeah, Tom, I mean, I think you and I have talked about this before, but when we think of standardization, we like a lot of folks, I feel like, think of surgical procedures or procedures that may be going on at the bedside, but in reality, the blood pressure and other vital signs readings, they really trickle down, right? I mean, how significant are the vital signs and their accuracy to the rest of the experience and frankly the outcomes?
It's a great question. If you think about blood pressure and its central role and essentially many disease states, most of the metabolic disorders and several others, and cardiovascular, of course, being one of those as well, it's imperative that you properly attain the key metric that helps you to define what you need to do for a patient that centers on blood pressure. The second thing it does is it allows you to risk stratify a patient more appropriately, so that if you have an accurate resting blood pressure, you know how risky that patient is for developing complex, costly, and potentially statistically mitigating issues that could impact your incentive comp. So what we're finding is that standardizing basic functions in the exam room is considered to be one of the most essential issues of improving your performance, but it also is very difficult because you got to corral your whole care teams around a central theme and make sure they're complying with it in a particular way. So I feel that this clinical standardization issue is really where the health systems are right now. They've integrated the infrastructure of new physicians into their environment. Now they're looking at how can we make all these care teams follow the same evidence-based protocols in a way that we know that the data is the same, office A to office B to office C, so that they can do the comparative analytics to make sure that they can successfully impact long-term care. But yeah, to your point, it goes right down to the basics of the basics, the blocking and tackling of doing a good blood pressure.
Well, wonderful. That takes us to the top of the hour. So, Dr. Tom and Kurt, thank you so much for your wonderful presentation. And now it's time to conclude today's webinar. A special thanks to our audience for the great questions, and thank you to our speakers, Dr. Tom Schwiegerman and Kurt Forstoffel, for your thoughtful contributions. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd like to thank the sponsor of today's webinar, Midmark. For more information about Midmark, please visit midmark.com. This webinar will be available on demand, and a link to a recording along with a copy of the slides will be emailed to you within the next 48 hours. This concludes today's presentation. Have a great day. I like that end slide.